Okay. All right. So for those of you who don't know me, I'm Brian Helsel. I guess you got my slides. Wow, that's crazy. But the idea is to try and do some stuff that's education for you guys, to kind of go over stuff that we do, patients that we have, and stuff like that. And so the idea is to kind of provide some education for you guys behind also, kind of learn us a little bit, kind of learn some different things about it, how we can do things better. I think this is also an opportunity for you guys to tell us stuff that you think we can do better, you know what I mean, to make things better, and then also a chance for us to try and help educate you guys, make you feel like you know what's going on more, understand what we're doing and why we're doing it and stuff like that. So there's a bunch of different things we can do. Stephanie asked me that you guys really wanted to talk about some thoracic stuff and all the different thoracic things that are out there. We literally could talk about this for days. So I have some slides, and this is about lung cancer. So the idea is to teach you a little bit about lung cancer, and I think you have to understand staging and diagnosis to understand why we do what we do, and then try and go from there. And then at the end, I think we can just talk, just kind of have a group discussion or whatever about whatever you guys want about things you've seen, stuff that's going on. And please don't hesitate to stop during this. Some of the beginning part is just monotonous kind of oncology stuff because it's a lot of staging and things like that. So it's not meant to bore you, but at the same time, it's meant to give you some information. But it's a little overwhelming too. So if you have questions, please don't hesitate. So we'll look at the staging for cancer. And so you'll often see non-small cell lung cancer is what that stands for. So you'll often see people use that. That can be adenocarcinoma or squamous. And then it's TNM staging like everything else. So tumor size, number of lymph nodes or where they are, and then metastatic stuff. That's the way every cancer is staged. And there's a lot of stuff, if you have interest in it, the NCCN has a guideline thing that you can look at if you ever want to figure out how people decide what they do and the progression they do, and to include surveillance, how the history and physicals are done, who does what and when. And it's NCCN, so the National Comprehensive Cancer Network. And you can go to NCCN, I think it's .org. If it's not, it's .net, and you can sign in, get a password, and you can see the flow sheets and how it's diagnosed and staging criteria and how it's staged in general. So, and then we'll talk about diagnostic procedures, and then we'll talk about curative intent procedures. So hopefully the second half will be a little bit more fun because we'll talk about some patients that you guys see a little bit more. So this is lung cancer in a nutshell with just a little bit of a breakdown. But I think the biggest things to see is over there on the right is T1 to 4. And so the specifics about all that are probably not nearly as important. And if you ever needed to know, you can just know that you can look it up and you can find it. But just like everything, kind of understanding the terminology is important. So TX means basically X and anything means we don't know. T0 means there's not a tumor. So sometimes what that is you do a biopsy and you can't find anything, so you say T0. But you shouldn't see any patients have anything major done to them with T0. TIS means it's in situ, so we see some changes and it's carcinoma in situ, which means it's not a full cancer, but it's not normal either. And so lung cancer, you don't see that nearly as much, but breast cancer and colon cancer with polyps and stuff like that, you'll see that be a lot more prevalent. And then 1 to 4. 1's the easiest or least to smallest, however you want to think about it. 4 is the most advanced locally. So this is about tumors themselves. So it's not nodes or metastasis. This is about tumors. So it's all size. So 1 is kind of 1 to 3 centimeters. They break it down. Under 2 centimeters, it's 1A. Above 2 centimeters to 3 centimeters, it's 1B. That's kind of how it works. Up to 7 centimeters, I think, is T2, 3 to 5 is A, 5 to 7 is B, and then greater than 7 centimeters. But then there's all these caveats in here. A T2 tumor that involves the main bronchus, invades the visceral pleura, associated with atelectasis obstructed. So there's things in here that if it's lesser, it can be brought up a little bit because it's doing something locally there. Like you've seen guys that have tumors and their whole lobe is collapsed. So that's obstructive pneumonitis, and so that will upstage them. So if you have 2 small, tiny T1 tumors in the same lobe, that's considered T3. So separate tumor nodules in the same lobe makes you a T3, even if they're both 2 tiny things completely separated from each other. A tumor in a separate lobe takes you to T4. So that's evidence of maybe there's something crazier is going on that you have it in two different lobes, even if it's on the same side. So that's kind of how it works. So it's basically a size thing, but then there's some criteria, like does it invade the mediastinal pleura, does it invade the aorta, does it do some of these other kinds of things. So then lymph nodes are assessed the same way. NX means we don't know, N0 means you don't have any lymph nodes positive, N1 are closer to the tumor, N2 are further away. So let me see what this next picture is. So this will help us see it here. So N3 is contralateral. So ipsilateral, same side as tumor, right? So for an ipsilateral tumor, you always want to see stuff on the same side. If it's gone to the other side, it's always way bad. So that's always N3. So if you got a lung mass over here and you got a node over here on the other side, that's bad. Even if it's like just on the other side of the trachea from it, that's bad. If it crosses midline, there's worse to that. So there's a whole bunch of lymph nodes here, and the way I like to try and explain it to patients is the trachea is like a tree upside down, and then you have a right tree and a left tree, and then the tumor is out in here usually somewhere. The lymph nodes that are 10 or greater, so there's 10, 11, 12, they're all out in the tree branches. So the further you get out toward the tumor, the lower the lymph node stage is. So it would be an N1 tumor. So we know all these areas, and so when we send it, if you look at our notes, it'll say level 10 lymph nodes, level 10R lymph nodes. Those are 10R is right here at the main bronchus. So those are 10R lymph nodes, or 10L right here because it's left side. So 10L lymph nodes that we sent. So we're trying to help stage. And so the more lymph nodes that we harvest and they look at, the better staging you get. Because really staging is it's like an apple with a worm in it. You know it's got a worm in it, but how many passes with a needle do you have to get through it to actually find that the worm is there? Well, the more bites we take, the more accurate our staging is going to be. But at the same time, you don't want to eat the whole apple because in this case, the apple is something important to us, like your lung or whatever. So that's the idea. So you'll see these lymph nodes that we mark, and so this is 10, 11, 12, 13. Anything that's a single digit lymph node is a N2 node. So all the N2 nodes are very important. So you'll see us do mediastinoscopy a lot. And we do mediastinoscopy because we're trying to find central lymph nodes that are positive. If an N2 lymph node is positive, that's stage 3A disease. That's the break point of where surgical intervention is helpful versus where surgical intervention is less helpful. So 3A disease, so that's taking T, N, M and putting that all together, and you come up with a stage. When you get to 3A, it works the same, 1 to 4. 1's not much, 4 is metastatic. So when you get to 3A, that's where surgery is. If you have to have a pneumonectomy for a 3A, clearly do worse at surgery. You clearly do worse in outcome having surgery than you do by having adjuvant therapy, meaning chemoradiation. Lobectomies are on the borderline. So a really good candidate, a young person or somebody that's viable, you might be a little bit more aggressive about it. But that's the reason we do all these mediastinoscopies. And you'll see we do MEAD possible, VATS, wedge possible, VATS lobe. Here it's way more difficult because we have so much histoplasmosis in our area. It's just endemic. And so people will have PET avid CTs with mediastinal adenopathy, a pulmonary nodule, and we don't have a diagnosis. The nodules are too small to really stick a needle in. The lymph nodes, we have to get aggressive about getting them. Sometimes Dr. Farrow can do some EBUS for us, and his group can help us do that, and that's helpful. The problem is you have this avid mediastinal adenopathy, they stick a needle in there, and it's negative or non-diagnostic. So then they'll always come to us and say, can you do the MEAD? Can you get more tissue? Because it's all about tissue, right? Tissue is the issue, is what they say. So we can get a little bit more aggressive and actually take full lymph nodes out and some things like that. So it helps them feel like negative is truly negative. I would tell you a lot of other places in this country, PET's very good. If the PET's positive and it correlates with the mass, you can almost guarantee that it's positive. You don't even have to do it. People do it to have tissue because it makes a difference in the way they're diagnosed, but here, I can tell you it's different. You can have massive PET adenopathy in the mediastinum and you won't see it. So these central lymph nodes right here, they start right here. There's level 1, there's 2, there's 4, 7 is just below the carina, 8's along the esophagus and along the aorta. Level 9 is on the inferior pulmonary ligament, right where the inferior pulmonary vein is. But they're all central. Anything that's a single digit is central, and it's an N2 node. So we're always going after these N2 nodes. And so when we do lobe resections and stuff like that, we take N2 nodes too, because we're trying to stage. Because sometimes we think they're negative, but we find a bunch of N2 nodes that are positive. Boy, that's a bad thing. They really need adjuvant chemotherapy. So they get their lung resection and further therapy. The nodes being positive at a lung resection have nothing to do with, did I get it all? You know, it's basically, I tell patients it's like a sign in the road. This way, negative nodes, this way, positive nodes. Negative nodes means everything we think is contained, and the tumor, as long as the margins are negative, it's all resected. And so that's cure. Sometimes they need some adjuvant therapy based on the size of the tumor or something like that. If they go the other way, nodes are positive, it's almost always adjuvant therapy. So that means chemotherapy. Typically, if the tumor is completely resected and the margins are negative, no radiation's needed. Radiation's basically for gross residual tumor. So if there's gross residual tumor, you'll get radiation. But typically, after a resection, if there's nodes positive, you'll just get chemotherapy. And so it's whether you need chemotherapy or not. So we're trying to help accurately stage people. So we could say, oh, it's a stage 1A because it was T1N0. But if it was really T1N1, they might need chemotherapy. So the better we stage the lymph nodes and do that dissection, the better we stage them and the better therapy they get, and hopefully their long-term outcome is better. Because really we're looking at 5 years, you know, and we'll look at 5-year outcomes with this. So this is just another look. Right up here in the AP window is what we call this, is the aorta and the pulmonary artery. Right in that little area where the ligament is there, there's other lymph nodes there, 5 and 6. So they sit there. Those are also N2 nodes. And so we try to get those too. So they're only on the left side though. And then down here you can see that anterior posterior is where you see the 3 nodes more. Really the ones we go after, 1 is so high up in the neck it's usually not an issue. 2 and 4 are kind of what we do, and we do it typically on the side of the tumor or wherever we see the adenopathy. And sometimes we're just trying to do that for whatever. So the closer you are to the tumor, N1, and those are greater than 10, 10 or greater. If it's a single digit number, it's in the middle, and then usually they should be accompanied with 9R, 9L, 4R, 4L, because that way you know what side it is. Because if the tumor's over here and a 4L lymph node's positive, that's N3 disease. So then that's even worse. N3 disease makes you 3B, which is clearly adjuvant therapy is better. So questions? It's a lot of craziness, but hopefully just trying to demystify the numbers for you a little bit. So there's charts like this if you ever needed to know or wanted to know, or you look at somebody's chart trying to figure out the deal, that's how you do it. So a little bit blown up picture here where you can see it again. So small digits here in the middle, 10 or 9 or less, and then out here on the tree is where it is. The further out you get, it doesn't really change anything, but nodes toward the tumor are less concerning than nodes that are way more central. So then the last category is metastasis. So it's kind of getting easy. You either have something distally or you don't. So separate tumor nodules in a contralateral lobe is metastatic disease. Tumors with pleural nodules is metastatic disease. And so sometimes we'll go in there and we'll see a tumor nodule or a nodule on the chest wall. We'll take that down and have them tell us. Because if that's on the chest wall, that's advanced disease. And they've moved that from metastatic disease now to a category where you can operate on a little bit. And then other things. So extrathoracic organs. So in a lung cancer, where would you expect it to go? Spine? Brain. Brain's a good one. What else? Liver. There's a couple big ones. Brain's probably the biggest. Where else would you say? How about this? How about on a standard chest X-ray or standard CT scan, why does the CT scan go all the way down into the belly? Does anybody know? Well, the lungs go down in the back, right? So they're deeper in the backside, but there's really another reason. There's a whole other reason for that. Does anybody know? It always will include the adrenals. The adrenals are way bad for getting metastatic disease from lung cancer. So they're always into the abdomen that much to see adrenals with a chest CT, because if they find a lung mass, they can look for metastatic disease in a common location, which is the adrenal. So adrenals and brain. So what about a guy comes in and he's got I don't know, low stage 2 lung cancer, and he's got a brain met. I guess first, what do you think you'll see? You think you'll know that, or is that something that you just find? I think oftentimes you're going to know it. They got something going on. They're going to have a headache. They're going to have some kind of symptom, some kind of neurologic symptom that's going to be different or new. So what do you think about that? They got a brain met, and we're going to call them metastatic. Surgery or no surgery? Surgery. It's one of the few places you can have an isolated brain met resection by Dr. Wiles and his crew, and you can have a lobectomy and still have a reasonable outcome. Weird, but adrenal too. So sometimes we'll have people like Dr. Lee take an adrenal out, and then we'll do the lung. You know, those are two reasonable cases where people can expect some outcome with it. But other places, like she was saying, bone and things like that, those are not that way. Those are much more aggressive, advanced when they're there. But you don't see them as much, but you'll see them every now and then. So brain and adrenal are probably the few that you can do. So here's the big algorithm. So you're a T1, have no nodes, you're a 1A. So let's say you're T4. Let's talk about those other ones. So N2 falls you right into 3A, everywhere except where there's a T4 lesion. But you would expect as the tumor gets bigger that the lymph nodes are going to get worse. So it kind of makes sense that over here is going to be the worst and up here is going to be the better. It's kind of where they fall out in the middle. So this is how the chart will look. This is kind of a way to put it in your mind of T2A. So this is 3 to 5 centimeters in size, and then lymph nodes. If there's no lymph nodes, 1B is really just surgery and maybe some chemotherapy, maybe, depending on what happens. Consider it is what they say. 2A is more of a stronger recommendation for adjuvant chemotherapy. So you could have a T1A lesion. If it was just N1, you'd probably get some adjuvant chemotherapy, and that would be it. But here you start getting into bigger tumors that have mediastinal adenopathy. These start to get to be the people that you start to say, how viable is this person? Is this a dude that's still working and still doing pretty good and has great lung function? Maybe you get a little bit more aggressive. I would tell you there's a lot of debate about N2 disease and 3A disease in lung cancer. Lung cancer is really mean, so you can look at it a couple different ways. Sometimes if they're a real viable patient and they're willing to quit smoking and do some things like that, it makes sense to do it, you know. And some places, and it's not unreasonable, as long as you can do a lobectomy. But if you have to do a pneumonectomy, clearly bad. Clearly worse outcomes by doing a pneumonectomy. And that's probably just because it's central. And you've seen these guys. Pneumonectomies are tough. I mean, it's not a bad operation. It's really actually pretty cool. But at the same time, them tolerating that physiologically, it's a monster. You know what I mean? Especially a right pneumonectomy. So anyhow, I think a lot of people are coming to the consensus that if you have 3A disease, you should get neoadjuvant therapy. And neoadjuvant therapy, is there a response? So if you see clear response, then maybe you go after them and do surgery. So kind of trying to select biologically the patients that respond a little bit more, you know what I mean? So if they respond to an adjuvant therapy, then maybe that tumor is not as biologically aggressive, or we have a way of treating it. I think a lot of times what you find out is they're not very amenable to doing that, so they don't get better. So then there's no sense. They kind of self-select themselves out, which is good. You don't put somebody through a lobectomy if they're not going to get better, and maybe that's a way to help figure that out. So this is kind of a scary curve. So prognosis. You see this right here? What's that? Stage 1. What's that say? Months after treatment. So here's 5 years. 5-year survival is under 50% with stage 1 lung cancer. That's treated. It's awful. We're getting better with therapies and stuff like that. We're doing better with, getting them treated early. The whole lung CT scan, screening studies are helping us and stuff like that. But this is why you start getting worried about doing big surgeries on people. I mean, their survival, even with treatment, is under 20%, approaching 10% for stage 3A lung cancer at 5 years. And it rapidly falls off here. There's clearly a difference in these two, you know what I mean, from the rest. So how much do you do to a patient like that? And, everybody when they're coming to this diagnosis is certainly in a different spot, you know what I mean? but you certainly have to be able to build some relationships with them and help them figure it out, because having some wicked operations is not necessarily, I mean, as much as they're fun to do, having patients do well is really probably more important than anything else. Do you know what I mean? So the real joy of these operations is being able to, take a patient home and have them come back to the clinic and say, man, I can't tell you how much I feel better, or how much this helped me, or how good I feel about it. That's the crack cocaine that we're all working for, you know what I mean? It makes a difference. So it's good to keep in perspective how bad the prognosis is of lung cancer. I don't think people realize how tough lung cancer really is. And I mean, even a stage 1A cancer, less than 50% survival at 5 years. So more lymph nodes only. So stage 1 lung cancer. So we're going to look at the stages now. So you take the tumor out, you remove some lymph nodes, and then the questions, depending on what you find, do you do chemotherapy or radiation? Stage 2 lung cancer, so cancer's in the nodes now, not these up here kind of close to the tumor. So then surgery, and then maybe chemotherapy plus minus radiation, depending on whether you have something positive. Stage 3 lung cancer, so bigger tumor now. If it's ipsilateral, surgery or radiation with chemotherapy, we talked about that already. So this is the 3A patient versus definitely not surgery for the 3B patients. And then stage 4 is really when it's in different places, like you were saying, bone, liver, and then adrenal and brain we talked about. So here's the fun part, talking about what we do. So here's PET. Does anybody know how PET works? How's PET work? Okay, to what? So it's glucose. So what we do is radiolabel glucose, and then we give glucose to the patient, so we infuse it. And what happens is it goes to places that use tons of glucose. So things that use a ton of glucose are our brain and our heart. So those are always going to shine brightly. So PET will never help you with anything to do with metastatic disease to the brain, but it will go to anything that's actively using glucose. So tumors will do that, and infection. In this area, that's why PET's tough, because a lot of it is inflammatory granulomas, it's histoplasmosis in their mediastinum. So you get tons of people that have PET-avid mediastinal lymph nodes. And so then what do? And then they got this nodule. Well, a nodule can be histo too. It could be a granuloma, and we're just catching it in evolution. It's not gone all the way to a calcified nodule. So then we here end up doing a lot of them because they're small. So we'll do a MEAD, trying to figure out whether there's cancer. So if there's cancer, you're kind of done, right? Because then you kind of know that you're already at 3A disease, and then it's whether surgery's helpful or not. And so then you kind of start plunking those people into the category of let's do chemoradiation. And they can tell from these lymph nodes, they're pretty good at telling us where they're from. If it's lung or whatever is an origin, because other places will go to the mediastinum too for spread. And then if it's negative, we'll do the wedge. So we'll try to do VATS, minimally invasive wedge, so that biopsy is less dramatic on the patient. So we'll try to wedge the tumor out. Sometimes it's real easy because they're on the periphery. Sometimes it's a real disaster because they're way deep. Sometimes it requires a lobe to get them out. And so then you got to figure out how much do you really think this is a tumor versus, just something else. Because the other thing you can do is watch. In 3 months, usually it won't change so much in 3 months that you upstage them or do something, but you also help select out the people that maybe it disappears in 3 months. If it disappears, it's good. It's not anything bad. If it stays the same or slightly bigger, then it's something that's a little more worrisome. So anyhow, PET will help us because it will go to these things, and that's how it does. This is old PET. Old PET was these pictures like this, and I think they have better monitors for them to look at than us, but you can kind of see where it's picking up. Brain picks up hot. This is the myocardium, so it's that kind of U-shaped thing of the myocardium. And then there's something over here in the chest. But now PET's really a lot more, it's a lot better study because they overlay it to CT. So when they overlay it to CT, you can now see whether that hot spot correlates to a radiologic abnormality. So when it correlates to radiologic abnormality, then it makes a lot more sense. Okay, there's a nodule in the lung and this hot spot's right over it. You can kind of put that together in your brain on the other one, but now it's just so much more clear. And sometimes they're not right on top of each other, so it's harder to tell. This makes it much more evident for you, and you can look at it, and then you can kind of see, is there adenopathy where it is, and the other one was a lot more nebulous where it was actually hot. So this CT fused PET stuff really makes it better. And so we have that here, and they do all that stuff for us. So Radiologic diagnosis, this is the 18-fluorodeoxyglucose tracer. It metabolizes in tumor cells. It's phosphorylated and trapped within the cell. That's how it stays bright. It's not specific to cancer, so inflammation can do it. And then we talked about brain, heart, and lung. So tissue diagnosis. So how do you get a tissue diagnosis? Well, you just go where the tissue is. And like we said earlier, tissue is the issue. So if you have a cervical lymph node, that's easy. You just cut down on it and take that lymph node out. Sometimes you can stick a needle in it. Sometimes you stick a needle in it, but then you don't get enough or whatever. So, and then mediastinal lymph nodes. So mediastinal lymph nodes are right here around the trachea, basically. So it's either at the bifurcation just below it is level 7, and up along the trachea itself is 2 through 4. You can't really get to 5 and 6 because they're out here kind of over the aortic arch. And so there's people that talk about it, but I think that's a little crazy. So how can you get there? So we can get there with transbronchial biopsy. So that's what the pulmonologists do. So Farrow and all those guys, they do what they call EBUS. So endoscopic bronchial ultrasound. So they stick a probe down there with an ultrasound on it. They can see through the trachea and they can see these lymph nodes, and it's got a right angle thing on it. They can pass the needle out and they can get a sample of these lymph nodes using ultrasound guidance via the trachea, just like they do a bronch. So it's awesome. A lot of places, they do this a lot. Here it's difficult because we get these negative diagnoses and we just still don't know what to do because of histo. Mediastinoscopy is what we talk about. So a lot of people will call it CME, which is cervical mediastinoscopy evaluation. And then anterior mediastinotomy, that's another one. So we'll talk about that in a second. Then we talk about thoracentesis and pleural biopsies, and then we can talk about lung biopsies and wedges. So the key to mediastinoscopy is a collar incision. So it's the whole idea that following the trachea, you have easy access in that plane. You can make a collar incision just like you're doing a trach, go right down to the trachea, and as soon as you get to the trachea, there's a little bit of flap of fascia that's there. You can grab it with a stitch, and you can just take your finger, and I can slide it all the way down to the center of your chest, and I can touch your carina like that. So that's what we do, is we put them back, put their head back if they can do it, make a little incision here, expose their trachea, and then you can stick your finger all the way down there. And then what we do is, it's almost like you're intubating somebody, but it's not. You go through that little incision, you stick the scope down in there, and we can reach down there with these instruments, and what we do is, push on stuff until the lymph node will just pop out of the fat at you, and then you just start grabbing hold of it. The problem is, look what you're doing. You're going right behind this is the innominate artery right here. So you're right behind the innominate artery, right behind the arch of the aorta, and then the main pulmonary trunk comes through here on both sides. So when you're right down in there, the things that are right above you are the innominate artery, the aortic arch, and the pulmonary artery, and right over the carina, past those lymph nodes, is the dome of the left atrium. And the SVC is off to your right here. So it's tiger country. I mean, really. If you've never seen a mediastinoscopy go bad, you don't have to be around long and you see one go bad, and it's a disaster. So it's kind of dangerous. And so we hate doing them because it's really dangerous. There's a lot of bad stuff in there, and you grab hold of the wrong thing and pull on it, you'll fill that hole full of blood in your face faster than you know what's happening. So, and then then you're talking sticking your finger there, holding it down, having somebody else open the chest, going on bypass to fix it, and it's tough, But at the same time, it happens, and so the whole reason to do this, though, is these mediastinal lymph nodes. Fortunately, we do a lot of it, so we're pretty good at it, and people are smart. You stick a big old long needle down there and stick it with a needle first and see what it looks like. If it doesn't draw back blood, then it's probably okay. And so sometimes you just don't know. Sometimes the nodes really look like nodes, so it's real easy. Sometimes they're abnormal looking, and so it's hard to tell exactly what you got. And sometimes they're calcified in there, sometimes they're plastered in there, sometimes they're different looking. And all these lymph nodes, if you notice, they were always in the bifurcations of the lobes and stuff. It's right where all the arteries are. They have to have a blood supply to them, so it's dangerous. So that's how we do it. That's how you get there. Trying to see. So this is the scope right here. So the incision's right down here in the neck, and this is kind of a scope with a light and just working with an instrument. They have better ones now. We're trying to get a better one now that actually has a camera up on the top of it. So if you guys ever wanted to come down and see it, hopefully we'll project up onto the screen and you can see exactly what we're seeing as we do it. But that also helps, like, who's helping you. They can see what you're doing, and if you get into trouble, they can know it right away and kind of react a little faster and stuff. But anyhow. So AME is the other one, anterior mediastinal exploration. So this is a way of trying to get to these level 5, 6 lymph nodes that we talked about that are in the AP window. So that's off to the left chest a little bit. The arch kind of goes back really more than anything. And what happens is right between the pulmonary trunk and the aorta, there's lymph nodes that are sitting there. And so what we're trying to do is diagnose that. And sometimes you don't do this as much, but the people that you do is, like, I did a lot in the Army because we had a lot of young soldiers that would come in with mediastinal adenopathy in the AP window. And the reason that is because young kids can get lymphoma, and young adults will get germ cell tumors and lymphoma. And so oftentimes we were diagnosing lymphoma or germ cell tumor with those things. And so it's pretty crazy how to get there, but what you can do is this is where the incision is. This is the sternal notch that you can kind of feel on yourself, that little pointy part on your sternum where it goes from manubrium to sternum. Right below that is, the second rib is right there, the third rib is below that. You kind of go right in between there. You make a little transverse incision on your anterior chest. You come down to the rib head that's there. You open the periosteum over it. You shell out the bone that's there. So you shell out the bone. You make a cut in the back of the posterior part of the periosteum, and right there is the internal mammary artery. So you can either slide it out of your way, or some people will transect it and just put clips on it and transect it. And then right behind it are those lymph nodes. So you can kind of push the lung out of the way, and right there will be the lymph nodes. And so then you're just kind of reaching down in the big hole, kind of right where the PA and the aorta are, and you can take those lymph nodes out. So this is also called a Chamberlain procedure historically, and so this is what they do. So now we'll move to VATS. VATS is exactly what you think it is. So video-assisted thoracoscopic surgery. This is kind of how it's set up. Everybody kind of gets bumped on their side. This is a little bit exaggerated here, but the whole idea is we put them on their side. We try to put their hip right where the break in the table is, and then we just really flex. What that does is moves the hip out of the way because everybody's kind of hourglass shaped. And so trying to get the hip out of the way allows us to get in the chest so that when the instruments are there, the hip really gets in your way of just trying to get down and look up, So we have these angled scopes and all that stuff, but they basically get positioned like this. You can see this is not one of our usual patients. So the difficulty really honestly becomes getting them onto their side, getting them positioned, and really, having them be able to tolerate flexing like this. Some of these people just won't flex like that either. They have had back spinal surgeries or whatever. So it can get to be very difficult to get some of these patients into the position and do that. It's, you kind of kid around about it, but it's true. And then the more stuff you have to go through, the more their hips get big, the more they get in the way. It gets difficult. It's not that you can't do it, it just gets difficult. And so what else do you think about VATS? What else do you think you have to do with VATS, right? I guess I'm asking you to think what I'm thinking, but you have to be able to ventilate with one lung. If you can't ventilate with one lung, you can't do VATS. There's no space in there. So if you can't tolerate one lung ventilation, ain't a lot we can do for you with VATS. You have to have a space. So you have to have some lung function. But most of the time we're going there to take out lung. If you don't have lung function, it's not much we can do. So the option to that is, if we need to do a wedge, is you just make a small mini thoracotomy, and you just try and feel in there and feel that piece of the lung that's got some tumor in it, and you try and slide it towards you, and you try and just wedge it out with the lung up, or you just have them hold ventilation for a few minutes while you're doing that. It's just like them holding their breath. You just disconnect them from the circuit, let the lungs come down a second, grab the lung, pull it down, start firing a stapler, and they hold their lung for 60 seconds or something, or until they start to desaturate or whatever, because they're usually a little bit more tenuous. But so you have to do that. The lung has to be able to come down so that you can get into space and have a cavity. In the belly, it's not that big of a deal. You just puff it up and everybody's got space in their belly, and you can make their belly stand out like they're pregnant. And so it doesn't, you make space. Here, you have to drop the lung to do it. There's no other way to do it. The ribs are tight. So, and then, there's all kinds of controversy about VATS. I wasn't a huge VATS believer until I started seeing some other stuff, but anything in the side of your chest is miserable. Honestly, even just a tiny drain, it sucks. It really, really does. The pleura is just so sensitive, it doesn't matter. miserable. So I was never a big believer in VATS because you have to make kind of a small access incision, and I mean, I can do a thoracotomy and take your lung out through an incision like that. I mean, you know, the access incisions are a little less. And then the problem is you start having ports everywhere. You know, with a small mini thoracotomy, you can put an epidural in, cover that one interspace pretty dang well, and you can do the whole lung operation fairly easily, and you know, their pain's not that bad. There's some arguments to getting them out sooner and stuff like that. I think academic people argue about that all the time. I think there probably is clearly some benefit from VATS. The first time it really made sense to me is I met a guy from England, and he does these, he calls them mini lobectomies or micro lobectomies, and all he does is put 5mm incisions in. There's a secret way we can get in without hurting the lung. Kind of put CO2 down the port as you do it, so as soon as you pop in, the lung gets pushed down out of the way and it's already isolated. So you can get in real easy with these ports, and so the ports are tiny, like smaller than this pen, so you can get in there like that. And then the thing that really made a difference to me was you can make an incision right over the xiphoid, cut the linea alba, which is right there, stick your finger up behind there, and I can stick my finger in the pleural space from here, and it's so much easier to pull out a big thing from right here than it is over here. You know what I mean? It takes a little bit more work though. You have to have, the instruments are not as designed for that, you know, and in the abdomen it's not as bad because you can kind of move the abdomen around, push it around and get it. These are kind of solid. The ribs are kind of in your way and you only have so much room. So having bigger portholes, we can get curved instruments in there better. You can't get a curved instrument through a 5mm port. So trying to figure that out is a little challenging, but it's kind of fun because you can take the lung out from right here, you know, and I'll put the drain out here sometimes just because that's where my bigger hole is. And you can do that. So it's just an idea of trying to make it, I think we've all seen laparoscopic stuff. I think laparoscopic stuff is clearly better than open abdominal stuff if that's the right thing. I'm not saying it's perfect for everything, but, and you can, you know, if you think about this, the abdomen will make a round hole a lot better than a rib will. You have to open it a lot bigger length to get ribs separated this much. So I've been doing that a little bit, but you know, it's hard here. Our instrumentation for 5mm isn't great. So Palazzo and I have both been doing kind of regular VAT stuff, and he's really good at it too. So it does help to have the smaller incisions, and they do very good with it. And so, you know, it's helpful. So what I hope to do here is show you a little bit of pictures. So I can't really tell what that is. I think that's just a stapler on the lung right there. It's just kind of bright. It's hard to see. I don't know if turning the light off will help you. Yeah, that's what it is. So this is just a stapler. This is an old school stapler, and this is just stapling out some lung. So we try to use staplers as much as we can. I think the advent that VATS has really brought us is instead of, we used to separate the lobes and find the artery and the fissure and find the branches there. I think that's where the lung leaked a lot of air for us in the old days, and the air leaks were a lot worse. I think the thing that's clearly gotten better is air leak has gotten better, but you can do this open now too, but they had to come up with a technique. So what they did is they started pulling the lung back this way, started pulling the pleura and the hilum back the other way, and they started finding the vessels down below, and they started getting really good at the anatomy of kind of following the vessel out and pushing the lung back and kind of rolling it back as you do and kind of dissecting it off the vessels and finding them. So then you're taking everything kind of at the base and you're really not dissecting anything in the lung. And then these staplers are so good. They fire 3 rows of staplers on each side, 3 rows of staples, and they cut right down the middle. So it, you know, I tell patients it's like a saran wrap of an air sponge with saran wrap on it. You know, so if you make a hole in that saran wrap, it's just going to leak air like crazy. So the less we do that, the better. These staplers do it way better than anything. There's a big deal about the staples. They're supposed to be B-shaped like that. And the idea is they compress the tissue well. They just also allow blood through that thing, because if you sew it shut, it gets hemostatic as well. So then you don't get blood to the staple line either. So getting some blood through those staples like that really helps have some nutrients so that it could heal, as opposed to making it completely hemostatic. And so that's where the staplers, I think, have really revolutionized that. And they're really designed for VATS. Everybody does them with the open stuff too, but really kind of pulling it back and getting the hilum first, and then coming across the whole fissure or parenchyma of the lung with a stapler. I mean, it's getting crazy. You can send people home in a day or two after a wedge like that. So anyhow, this is just showing you some bubbles on the lung that are blebs. And so this is sometimes what you'll see us do, these blebectomies, where they have little blisters on their lung, and that's just outpouchings of pleura. And sometimes in later advanced patients, it can be emphysema. So all these little tiny air sacs kind of coalesce together to make a bigger air sac, and now it's just one big air sac that used to be 3,000 air sacs. And you get into that little hole of that thing, and it just leaks air like a sieve. I mean, it's the bigger that thing is, the more directly it's communicating to a major bronchus, and so then your airway gets much more significant. So sometimes we'll resect these blebs off there like that, and we'll use the stapler. There's arguments to use reinforced loads and some things like that. I think it's all a bunch of crap and just probably stuff that I think it's stuff that makes money. I'm not sure it makes a difference, but it makes us feel better because, when you have to deal with the air leak down the road, we do it because, at least you tried. You know what I mean? So these are some bubbles that you can see, and that's a stapler. That's kind of an older school stapler, though. So let's talk about, so those are just more diagnostic stuff. So way to get mediastinal lymph nodes down the middle with mediastinoscopy. There's also EBUS, like we talked about, which is endoscopic. Some pure general thoracic people, and bigger centers, they'll have people that's all they do is thoracic. They'll do a lot of the same stuff that Pharaoh and them do. So they'll do EBUS, they'll do navigational bronchoscopy. So they're using a CT scan fused with this navigational system that they take right before they put them on the table. They do the CT scan, and then it's correlated with it, and it will help steer them out through all the bronchus to a point where they're close to a really peripheral tumor, and they can just fire a needle out into the direction that they need to do and get a biopsy. So trying to get more creative about getting these biopsies done without having to have even a VATS to do it. Because if it's not a cancer, it'd be nice to not have to have a VATS. You know what I mean? So AMEs we talked about for the AP window, and then we talked about just VATS wedges and things like that. So all kinds of different lung resections. There's a wedge, which is basically just kind of chomping out a little segment, or chomping out a little piece. I shouldn't say segment, because the next thing is segmentectomy, and the next thing is lobectomy, and the next thing is bilobectomy, and the next thing is pneumonectomy. So that all kind of makes sense to you guys, I'm sure. So what I did is I threw a picture of the anatomy chart over there with all the lungs segments on there. And so that's what people are talking about. So a lobe on the right, we certainly have 3 lobes. So when you say middle lobe, it's really always the right, so you don't have to say right middle lobe, but it's middle lobe, it's always on the right. You can see the segments that are there. The left lung is smaller than the right lung because the heart takes a fair amount of space on the left chest. And the lingula is really fused. It's kind of the middle lobe of the left side, but it's really integral to the upper lobe. There's not really a fissure, where the middle lobe oftentimes has a fissure and stuff. So right lung has what we call a major fissure right here, and it has a minor fissure where the middle lobe, so the middle lobe sits here. There's only one fissure in the left side, so typically if you get a lobectomy, it's either upper or lower lobes. The segments are colored in different colors so that you can see them. Some of them are bigger than others. There's people trying to do lesser resections on people to try and make it so that people are trying to figure out, does a segment have as good of an outcome as a lobectomy? Because then you're taking less lung out. The problem is you got to dig way further out on that tree to get that branch to take that out. And then there's not a fissure there that helps you identify where it is. So there's all these people injecting radiolucent dye and use a special like Woods lamp or lights to see where it is, or it changes the color to the lobe or something. So then you know where to staple out, because it's basically just a pile of tissue and like, where do I do the staple? You know what I mean? If I take the bronchus and the vein and the artery, well then where do I staple? It's not as easy as it sounds. And so I guess I haven't really bought into it yet, because I'm not sure that we know. I guess a couple things. One, I'm not sure that it makes any difference in outcomes. So like, I'm not sure that you help people by doing that. And I don't think we're going to have data for a long time to do it, because it takes many patients quite a few years to have outcomes enough to tell us that that's an acceptable thing. Lung cancer sucks. We already saw that. So I'm not going to take a chance with my patients to do a lesser resection when I know that a wedge is not good as a lobectomy. I can tell you that. But if a segment ends up not being as good for my patient, then I'm really not helping them until I know the data. There's dudes out in the world that are trying to figure that out. I have no desire to figure that out, but people are trying to figure that out, and that may be helpful at some time for us to know that. But right now, I'm not going to take my patient and do a segment on them when I don't know that it's going to do as well for them as I know proven data for a lobe is. And their outcomes in 5 years are tough. And I think in this area, our patients are tougher than a lot of other patients in other places. So I'm not going to take a patient that's tougher to work on, do a lesser operation to get an outcome that I'm not sure is beneficial. Because that's the issue, is trying to be sure that, the risk that they take is worth the benefit. The benefit's only worth it if the outcomes are proven. Now, doesn't mean that every patient's going to get that outcome, but at least you can go to sleep at night knowing that you told them it is the right thing to do. Whether that means that you're going to get better or not is a whole different deal. So let me see what I've got here. Okay, so let's talk about lung resection. So like we talked about, you have to have single lung ventilation. So this is the way it works. You can do two different ways. This is the clear way that's better, without a doubt. So it takes a little bit of effort and work to do that. You got to use a bronchoscope to get this down the right way. The anesthesiologists are really good at like just putting it down there and manipulating it a certain way, and they can get it down that left mainstem bronchus. But that's what they're trying to do. They're trying to get a left mainstem intubation. And so with that in the left mainstem, you can kind of do whatever you want. So if I put this balloon up here, even if I leave this other one down, they'll not do that. They'll usually put this one up too, but they'll clamp this tube out that goes to that lung, and they'll only ventilate this tube, and it's isolated right there with this balloon, and then they can just feed the left lung. So if we're doing a right lung operation, they'll do that, and they'll be ventilating the left lung, and the other lung will be passively atelectatic. It'll just slowly collapse down. And that way we can get in there and work on it, have a space and that kind of stuff. If you want to do the other way, what you can do is clamp the other tube and then isolate, put both balloons up and then breathe down that side, and you can do it. If you want to change and we're done and we want to check on the lung, all they got to do is take the clamp off and they can breathe both lungs. If they want to switch lungs, they can do that. Maybe they do something on this side and then do something on that side, like sympathectomies. Do both sides. Get the sympathetic chain for, have you heard that hyperhidrosis? People that have sweaty palms and underarms, you can do something to the sympathetic chain in the chest and transect it, and you can do it. So you can do the left side and then the right side, and it allows you to do that. The other way to do it is do a standard endotracheal tube. I don't have it. A standard endotracheal tube, and they have a balloon catheter that they can put down there. So they'll connect it to the end of the bronchoscope. It's got a little loop on it, and they snug it down to the bronchoscope, and then they kind of carry that with the bronchoscope down into whatever side that they want to occlude, and they put it down there. It's called a bronchial blocker. So you slide that down there, they can see where it is. You let go of the loop, slide the bronchoscope back out. You can see that it's sitting right there. You put the balloon up, and that lung goes down. It's a little bit more finicky. If it comes out, it's a little bit more of a hassle. You have to really have somebody that knows what they're doing to do it. A lot of people try to do it because they think it's easier. But what ends up happening is it actually takes a little bit more work, and they're not as facile, and they're trying to do the easy thing, and it becomes difficult. And so it just can be painful. And then you get them up on their side, and they're, then the lung's not working right. Now they're trying to do a bronch with a patient on their side with the drapes up. Really starts getting screwy. So this is just really secure. So sometimes you have to do things the other way, though, because if you want to do a high resection, sometimes there's a tumor right in here. And so what you want to do is actually transect the trachea, transect this, transect that, take that piece out or whatever lobe that is, and then you can sew all that crap back together and make it work. And those are called sleeve resections. That's kind of beyond what we're talking about, but more advanced things with the airway after that. So, so here's what I was talking to you about. This is, in the old days we did this. We got into the fissure over here, and we found the artery, and we found the arteries that were going that way, and all of us, every lobe has anatomy that's different. So basically you got to remember, you got to be familiar with all the different lobes, because you got to know where all the blood vessels are, all the variations to all those different lobes. You got to be able to do it. I think this part right here, that is what I was telling you about, that I think VATS has helped. We don't go in the fissure to find these anymore. What we do is start finding where they go in, and what we'll do is take a stapler and kind of stick it in here and cut it, and kind of develop the plane up underneath there, and then staple it, and then it starts to open up for us. And then we can see these branches like that and take the branches that we know go to the lobe and kind of handle it that way. So then everything is kind of done with a stapler, and really not much of that is done. Most of the time you can take some of this stuff and start rolling it back, and you can see the branches you need. And then when you need to come through the fissure like this, you just, we've already got all these branches, let's say, to the upper lobe already done, then you just come in through the parenchyma of the lung with a stapler, and then the air leak is almost gone. So that's what you have to do. So with every lobe has to be a bronchus, has to be an artery, and has to be a vein. So you have to get all three of those, and some of them have more than one. So the upper lobe tends to have this posterior segmental artery, and so you have to find that one as well as the main truncal branch that goes to the upper lobe, which is not in the fissure. It's kind of, you'll see it back in here more. So all that stuff is part of it. Like we talked about, lymph node sampling is ultra important for what we need to do to help make staging. Here's kind of a VATS in progress, so that you can kind of see patients up on the side. There's really not much to work with. They put these magnetic things there sometimes to hold instruments and stuff. You got one guy using a scope, so there's a minimum of 3 ports. You have to have a place for a camera and a place for 2 hands. Sometimes you can stick another instrument down one of the other ports, so if you kind of want to stick one instrument down and use a stapler, you could potentially get away with 2 ports, but generally it's going to be 3 ports, a camera and 2 hands. Sometimes a 4th one to have an extra person hold or something like that. So that's kind of how it's set up. Robotics is certainly out there. There's lots of people that are proponents of robotic lobectomies. I think you have to be in the right place. I think you have to do a lot of them. I think it's easy to do. The definition and stuff is great. I think the thing that the robot's really going to give us is up here in this top right corner, the wristed instruments. They're now working on wristed instruments for VATS, like I was telling you. If I get a curved instrument in there, it would make it so much better. So they're getting good at that. They're starting to make handheld instruments that will have robotic wrists like this, that you could kind of put in your hand and you'll be able to go like this and the wrists will move inside like that. That would be tremendously helpful for kind of making a corner and dissecting and making the holes smaller so that you can do that. So I think that technology will come. This is the way the robot works. It looks like a scorpion or spider that's killing the patient. I mean, it just got all these arms on it, you know what I mean? And it's kind of scary because there's only one person at the bedside. There's a PA or an assistant at the bedside, and that's it. The surgeon's over here in this console, and they're doing the operation over here. Something bad happens, it's time to get over there, get the thing undocked, you know. But a lot of times you can put something on it and hold it, and so they have usually a port site, or they take an arm off. They'll take one of these arms off and they'll stick something through there, and they'll be able to tamponade what's there, and then you can do a thoracotomy and get there. But it certainly takes a system of patients to do, a system and team to do that. You have to do enough of them. We probably do enough here to do it. I think all of us are not convinced that the money that's involved in it, and it certainly in the beginning for sure adds time to it. There's people that say that it doesn't. Some large thought leaders in thoracic surgery say that it doesn't and that the outcomes are superior. What I would tell you is I think it's a gimmick more than anything. We may get some good technology out of it. I think in a place like Sir Foley is a big guy in thoracic. He does a lot at UAB. He just left UAB actually, but I mean he'll do 12 cases a day, but they also give him 4 rooms to do it, and he goes from room to room to room. So it doesn't really matter how long the docking time and stuff is for the robot because he's doing another case when that happens. We don't live in an environment here like that. We don't have 6 rooms to us, you know, and we're all doing cases. You know, it's been nice this week for me because I can go from case in one room to case in another room to case back so we can get a lot more done just because there's not anybody else here this week. But, you know, when there's somebody else working, that room is full, and so you can't do that. So it starts to limit you, and if you start taking an extra 30, 45 minutes to dock a thing on top of what we're already doing, it starts to get to be time consuming. And these robots are several $1 million a piece. So we have some. I think there's a couple at Franklin Wood, so it's not like we don't have them. It's just a matter of, is it helpful? There's people doing cardiac surgery that way. I'm not sure that there's anything that it provides us that we can't do with VATS that we're not doing already. Hopefully some of the technology that they're using with it will make instrumentation and stuff a little nicer for us, but only reason it's helpful I think at this point is from a marketing standpoint to say we do robotic surgery, you know. I've done it. It's not hard to do. It's just a little different thing. You can definitely do it. I just don't know that it's that helpful. And then there's certainly things I think we could spend our money on here that were more helpful for us as a team than spending the money to do this or whatever. But it's not a bad idea if it helps us get more patients. Do you know what I mean? Like, because people say, oh, they do robotic surgery. Because I think if you can get people to the door, then you can talk to them about it, and then it's a different deal. But sometimes people will come because, oh, it's robotic, it's got to be better, you know. So I don't know that it is. I mean, it's definitely not bad. There's definitely proponents too. So don't. This is my opinion only. So conclusions, surgery is the best treatment for lung cancer. If you have to have surgery, if you have to have lung cancer, you want to have surgery. Because that one usually means it's lower stage. 2, there's the best outcomes for that. And one that's because surgical cures are so much better, I think, than anything else. But you have to be a surgical candidate. You have to completely resect it. You have to stage it well. The majority present with advanced disease, which is often the problem. It's not just here, it's other places too. They just don't. The problem is you don't know. But when you start having symptoms, it's so bad you know. And oftentimes when you have symptoms and you present, you don't know. So this low dose CT screening, lung cancer screening stuff is starting to bring more patients earlier. And so maybe that's going to be a better thing, that we're going to find some of these people earlier, which would be great. We talked about all the different things associated with the diseases and stuff like that. The only other thing that's not in this that I think it's worth talking about is radiation oncology these days is doing something they call, I don't know what you want to call it. Here they tend to call it gamma knife, but really the term for it is called SBRT, so stereotactic body radiation therapy. And so what they're doing is they're taking a special form of radiation, and if you can think about it, radiation is a beam, right? So if you just get frontal radiation, everything in front of you, they can collimate it down so it's just to where you need it, but that whole thing is getting kill dose through you. You know what I mean? The whole area. I mean, we kind of bring it down and try and get to where we need it to be, but all that's getting kill dose. So the idea is if we take many emitters of radiation and we put them from many different angles, they can all be lower dose, but we can map out an area on the scan that is that tumor, and that's the coalescence of all these beams of radiation. So kill dose on the tumor with a margin, but not anything else. So your heart can be more spared, the rest of the lung can be more spared, and things like that. And there is starting to be data that tells you that maybe there may be as good, I think there may be as good a local control with early, even a stage 1A cancer with that as there is with surgery. Now that depends on what surgery we're talking about. A good lobectomy, I still think it would be hard for anybody to argue that has better prevention of recurrence and better long-term survival. I think that's without a doubt. The question becomes these patients that are not amenable to lobectomy but we do a wedge on. I would tell you that if we get better at diagnosing these patients so that we know that they have cancer before we operate on them, they're probably better. If they're not a surgical candidate, they're probably better with SBRT than they are with a wedge. But the problem here is figuring out that they actually have it. You know, we talked about the histo and different things like that, but I think that's where in the world things are going, that if you're a non-operative candidate, there's now a really good therapy for you. Whatever makes you non-operable. Maybe it's your frailty, maybe it's your ability to get around, maybe it's even your lung function. You know, it's certainly going to take some of your lung function, but they're going to take a heck of a lot less lung function from you than I am doing even just a wedge. So I think without a doubt, SBRT is way better than a wedge. I would be willing to argue with people about whether it's better than a lobectomy. I think there's pretty clear data to say that there are categories that maybe it gets better local control. But the question then also really comes down to this. If we're treating this as a 1A cancer, they have to be 1A. And the problem is there's some selection bias. So these patients that we're doing SBRT on, we're really, really looking at them hard to figure out whether they have truly 1A disease or not. So if they're not 1A and they get SBRT and they've got mediastinal adenopathy or lymph nodes somewhere, we're not treating that with SBRT. So the question is are they going to get SBRT now and they've got good tumor control, but the reason their long-term outcome is not as good as lobectomy, which is true, is because they're actually understaged. And so they're really not a 1A. They're really a T1N1 or something like that. And so then they should have gotten some chemotherapy at the out front and they're not. I think that where the trade-off comes is in the people that can't tolerate an operation, and so that's helpful, you know. But that's where the mediastinoscopy comes in again. That's where good EBUS comes in to try and know that these mediastinal nodes are negative, trying to find out whether these hilar nodes. But the further you get out on the tree toward these tumors, the harder it is to diagnose these N1 lymph nodes out there. So, you know, it's kind of trying to figure it out. But it's not a bad option, especially if you're really not a surgical candidate for whatever reason. And there are places that are trying to determine whether it's as good as a lobectomy. But I think it's probably better in that you don't touch it and it gets killed, because I think there's probably some tumor spread from us just grasping the tumors and moving it around. But I think the problem is you don't get as good of a lymph node sampling. So there may be people that are thought 1A that are really not 1A that get this therapy, and then they're not getting therapy because we're going to harvest those lymph nodes. Those lymph nodes are going to be in a bucket. They're going to look at them and tell us whether they're positive or not. And so we can upstage people easier, and then they get more adjuvant therapy, and maybe they do better that way. I don't know. It's controversial. There's not a good clear answer to that yet. So did I kill you? That's about an hour, huh? Sorry. Is that helpful? Yeah. Sure.
I know we're crunched for time, but do you mind to elaborate just a little bit on the regional cystoplasmosis? I'm honestly not familiar.
Regional cystoplasma. Histoplasmosis. Sorry, histoplasmosis. Sorry. So histoplasmosis is kind of an endemic parasitic infection that lives in the Ohio River Valley. We're not really in the Ohio River Valley. Kentucky is a little bit more than us, but I think we have a harder population here in Northeast Tennessee. But it's an endemic infection that kind of lives around and can make you have granulomatous disease in your lungs and your medius tanum and your adenopathy. It's not anything bad. It's not that you take antibiotics for it. It's just people around here will have calcified nodules in their lung a lot more. It's probably a result of having these little infections that they get just being in the environment. The problem is we're getting so good at looking at stuff that we're finding them before they're the calcified nodule, and so now it's like, oh my God, is that a lung cancer? I don't know. What do we do? We're trying to figure it out, and we're trying to figure it out, and we don't. And the problem is we're finding these things, and they're all under a centimeter. And so when it's under a centimeter, it starts to get hard to put a needle into it. It gets hard for us to find it depending on where it is. People get freaked out about saying, hey, let's watch this for 3 months. You know what I mean? And even though, like I told you, in 3 months, you're probably not going to upstage anybody, even if they had a lung cancer. And you can some people just clearly the thing goes away. A lot of people around here, it clearly goes away. And then some people, if it stays there, you do something about it, or it gets bigger, then you do something about it. But it makes it much more difficult. You see a lot more PET-avid mediastinal lymph nodes and nodules here than other places. But there are also lung cancers. We operated on a lady not long ago, last week or the week before. I was trying to think of who it was. Had a PET-negative adenocarcinoma too. So you could be PET-negative and have a lung cancer. So it makes it tough. It's nothing straightforward, you know. And I don't know. It seems like cancer evolves and we figure out ways to beat it, and it seems to adapt and overcome somehow. So there's some of the challenges too. But yeah, histoplasmosis. Yep. What else? Chest tubes management. We can talk about all that stuff later if you have questions about stuff, or lung cancer or VATS, or I mean, you know, you guys always have a welcome invitation. If you ever want to come to the OR and hang out and see cases, you're always welcome to do that. You know, I think it's always helpful to have you guys down there. I mean, the only way we take care of these patients is to have a huge team of us. Do you know what I mean? And so I think all of us try to be extremely open to you whenever, you know what I mean? So that if you have questions or concerns about patients any time of the day or night, I think none of us care about you calling us. We'd rather hear and fix something early or know something's up or whatever. None of us sleep good at night if there's problems going on. It's just nobody wants to do something bad, you know what I mean? There's plenty of bad in our business. And so part of the reason we do this is we're trying to develop a team of us, you know what I mean? And so if you want to come down there and see what we do, sometimes it gives you insight into how we're taking care of patients or why we're doing what we're doing. Almost always, even if it's idiosyncratic about a way a certain surgeon does something, it's something's happened that's the way they do it. Do you know what I mean? And so sometimes if you come down there and see, you kind of see where the problems and the issues are, and then it helps you understand why the tubes work or they don't work, or what's happening this way, or why we do this or that. And so, you know, you guys are always welcome if you ever want to come down and see. You don't have to give us really any advance warning. You can welcome just to do whatever. We certainly, you know, I mean, it's a big team of people. I don't do all this by myself. Half the credit is to you guys and what you do and the care that you give to our patients. So, sure.
I know some of y'all have to go to work, which if you step out, it's fine. But I think pain control, like your choices, like you use the on-cue ball, or sometimes you use IV, and I guess just like that decision-making process and.
Not really any good decisions. If I can use a non-narcotic to make someone have good pain control, I will do it every time, because I think you're actually treating their pain. I think when it comes right down to it, I'm not sure narcotics really help your pain. I think it just makes you blitz to the point where you just don't care about it. So I think the problem is with the narcotics is it makes the patients more difficult for you guys to work with. And so what I'm trying to do is find a way for them to have pain control that keeps them interactive with you so that you can do pulmonary toilet and stuff. And to me, if that's Toradol, if that's on-cue pain balls, rib blocks that we place, local anesthetic, and the incisions, whatever, I'd rather use 10 times that than any narcotic. I'm not trying to be a complete jerk off and not give them any narcotics, because I think some people need it and it's appropriate. But at the same time, I'd rather have them more able to work with you as far as coughing, deep breathing, and I think it just makes them sedated and then they're less able to do it. But you do have to overcome that pain or you don't do it. Some of it's hard to do though. Pleural lining is so sensitive. The drain, sometimes it just kills people. But sometimes when I have really bad drains that are a problem, I'll just take a bottle of lidocaine and use a syringe and uncook the drain and pour lidocaine down the tube and just leave it clamped for a few minutes. It just bathes that whole area with lidocaine. Sometimes though they get the ringing in the ears and all that crap from the lidocaine, but at the same time it really works. And so sometimes it's really helpful. And if I can break that sensation, it's better. And I think, I don't know, maybe you guys will agree, if you put a chest tube in there and they have significant amounts of pain, that day it's not bad, but the next day, they get this huge inflammatory response and it seems like their chest tube drainage goes way up. And it's that way for a couple days. And I think it's purely an inflammatory response from the amount of pain that they have. So that's why I'm a believer in Toradol with it, because it cuts that inflammatory response. I know there's a black box warning for it, but there's also actually a fair amount of good randomized controlled data to say that people actually have better outcomes using anti-inflammatories because the pump is very inflammatory in nature. And so I don't know. I find that there's little risk to it. You have to have a normal creatinine and stuff like that. You have to be careful, but at the same time, I mean, I think if I can do non-narcotic adjuncts to make pain better, it's certainly helpful for you guys. And you guys helping them do pulmonary toilet and get up and walk and them being willing to do that and stuff, I think that's the key. So if I put a pain ball in there to try and do it, sometimes it works great. Sometimes it doesn't do crap, but I certainly think it's worth it. The problem is it's expensive to do, I think most of us do it, but at the same time, I don't know. It's just trying to find non-narcotic ways of controlling pain, because I think it actually controls the pain, allows them to work with you better, so. Yeah, no, I agree. Just generically, some people, they just doesn't do jack for them, but I mean, I think you at least try, and then, we try to put rib blocks in the chest before we close them and stuff, and that helps. The problem is it lasts a couple, it doesn't last as long. The on-cue pump's nice because it lasts for a couple days, which is certainly helpful. I think you can get through the first 48 hours, it's really helpful, so. That's kind of why I do the drains too. I think those smaller drains are less painful and stuff, and I've not really ever had a trouble with them. I've taken plenty of people back for bleeding, so I don't think that it doesn't drain good enough. You do have to work with them a little bit more, though. Some surgeons hate you guys stripping on them. I'd rather have you strip them, have them work, and have them patent. I have never had a thing where stripping the drains made anything worse. So I'd rather you strip the drains, have them working, than because I don't think stripping the drains has made the difference between me taking somebody back or not. They're either bloody and wet and there's something going on, or they're not. So strip the hell out of the drains and get them working and know how much is there and do that. That's how I feel. But I know that Chuck doesn't necessarily feel that way. So you have to be a little careful. But I mean, I'm being honest with you. I think the truth is there's blood there, there's not. Keeping the drains working is fine. Whatever it takes to do it. Now, I try to use the smaller silastic ones because I think they hurt less. So some of that's just preference, right? It's never. Yeah, I mean, it's like chest tube management in general is. If you want to talk about two things that are like endemic through every hospital, it's the way you manage chest tubes and it's the way you work an NG tube. I mean, there's some science behind it if you really look at it. There's some really easy ways to think about it. NG tube should never be on intermittent suction. It just shouldn't. Why was it on intermittent suction? I think if you understand the history of it, you'll understand why NG tubes are that way. What's that? No, I'm just saying. Why did we put chest tubes on? Why did we put NG tubes on intermittent suction? Because it used to be just a single drain without anything else. So it was a single drain, and what would happen is you put suction on it, the stomach collapses, it rolls up in the mucosa, it doesn't work anymore. So the way to get rid of it is unplug the suction, right? So what they did is they made intermittent suction. So it rolls up, gets stuck in it strains some, gets rolled up in the stuff, turn the suction off, it fills up with fluid, it comes back again, it will work again, you turn it on again, it sucks and drains, it gets stopped. But what they did is these new tubes, that blue port is an air port. So it's supposed to suck air through that tube at the same time it's sucking out. If there's ever anything coming out of that blue port, it means that it's clogged and not working. You just need to put some air through that thing and open that up, and it will drain again. So the idea is if we can keep it on continuous suction, it's better. It doesn't allow that fluid to build up. And we actually don't drain as much fluid as we do air. So keeping it patent and sucking it out is actually better. So if we can leave it on low continuous suction, it will work better. It just takes some work to do it. And you always find people tying knots in it. Well, that makes it the old school tube. It's not ever going to work that way. And if you put those clogs on the end of them, they're fine, but as soon as they back up, there's a paper filter in there that tries to keep it from leaking everywhere. As soon as it gets soaked with gook the first time, it basically doesn't work anymore, and it's just like putting a plug in it. So for me, I like to have it out, but I know nurses don't because it comes up and there's all this crap all over the bed and stuff. But really the idea is to keep that port open, and if that port's open, it should be sucking air at the same time it's sucking out so that it can't collapse it down and it continues to run that way. Chest tubes are kind of the same way. I mean, like in the old days, there were 3 bottles, and then there was a regulator, it was a regulator. And when I was in fellowship, one of the guys at Wake Forest he still had bottles, still had glass bottles. But the whole idea is, of suction and no suction is interesting. And if you start looking at the National Emphysema Trial, the thing that they figured out is, the one thing that probably good came from that is they did these lobectomies for patients that had emphysema in their apices. And they're worse than the apices because that's where all the emphysema is from smoking. It goes up. So they were doing lobectomies and they were trying to figure out what made people do better because they had these tremendous air leaks. And so they looked at stapled loads that had like some tissue on them to staple and to help reinforce the tissue and all that stuff. None of that stuff made a difference. What made a difference was less suction on the chest tube. So in the old days, we just said, hey, you got a pneumothorax, suck on it more, turn it up, and and what they're finding out is that's not the case. And if you think about it, it makes sense. It's a fistula, right? So it's an abnormal connection to the bronchus. So the more you suck on it, the more you draw air out, the more you're going to pull air through the lung, and the more you're going to keep that fistula open. And the longer you do that, the more that becomes an epithelialized tract that is a fistula. The longer a fistula is, and the smaller it is, the less stuff that comes through it, the more likely it is to shut down. It just won't going to have good flow through it, so it shuts down, heals. If we keep sucking on the chest tube a ton, we're pulling air out of the space, but we're also pulling air out of that hole too, and it keeps that hole open. You certainly don't want the lung to collapse to the point where the patient's symptomatic. So there's certainly a point where you have to do something. So it has to be enough air coming out that they're not symptomatic, that the lung, some people can't tolerate their lung collapse. Some people can tolerate all the way collapsed. It just depends on your lung function. But the thing is tension pneumothorax is what you don't want. So the tube is never going to let you have tension pneumothorax. So people have tried to talk about changing the terminology from water seal and suction to active suction, which is connected to the wall, versus passive suction, because the system should be sealed. So if it's sealed, it's a siphon. It's just like taking gas out of your car. Once you get fluid to flow through there, the thing is sealed. It's going to come out that way, and it's got suction on it even if it's not connected to the wall. That's why it has water in that little chamber that goes up the side, is that's the centimeters of water that it's drawn off in suction. I mean, it's just passive suction that way. So the idea is try to use the least amount of suction. There's surgeons that do big thoracic surgery that they put them on water, they put them on suction until they get to the PACU, and then they take them off. They don't ever take another chest x-ray. They don't ever look at it again because they don't want to hear about the pneumothoraces because they don't care. They just want to evacuate enough air, not draw air out, so they're not in tension pneumothorax. The lung doesn't have anything, and as they get rid of the atelectasis, the lung re-expands and fills the chest cavity. And so they don't want to hear about the pneumothorax, so they don't take pictures. They don't put it on suction, and as long as a patient doesn't develop a ton of sub-Q air or something, then they don't do anything about it. You get some sub-Q air, then you turn the suction on and help it come up. And as long as they feel okay, then you do it like that too. It doesn't always work. It's probably not the answer, but it's interesting to think about. It kind of makes sense. Chest tubes and G tubes are one of those things that It's lore. It's what the people in front of you taught you. You don't ever sit down and read a book about how to run an NG tube. It's because there aren't any. But there are people now that are starting to look at the things that we've done in the past and try and say, was that really smart about what we did, or are we just being stupid? And there's actually digital Pleurovacs out there that vary the suction so that they can tell where it is, and you can actually get chest tubes out earlier because you can see the rate of it coming down, and they can basically tell you that the air leak is gone. So they come out with this graft of stuff. It's a big fancy looking box, and there's data to tell you that it's better. The problem is it's pretty expensive too. So it's not worth it for the average patient, and a lot of places aren't going to spend that kind of money, but people that are really into, like trying to do whatever they can to minimize their lengths of stay and stuff will do that stuff because the amount of suction that those things use is just way less. It kind of regulates it based on what it is. I certainly can't argue that having the lung all the way up isn't probably helpful because it being up helps it stick and heal and some stuff like that, but there is a trade-off. There has to be a trade-off where you're sucking more out than you're really helping. You just can't have the patient symptomatic. So I don't know, it's interesting. I don't know the right answers, and if you had all three of us in here, we'd probably all argue about what it is, and we'd all it'd be the side discussion over here. We're all bitching at each other about it, but I mean, it makes some sense. I don't know what the right answer is, but I'm certain that there's some difference in there a little bit. So I would tell you the least amount of suction that you can use through a chest tube that keeps the patient not symptomatic, not with subcutaneous emphysema, and keeps the lung up pretty much is helpful. But the least amount that it takes to do that, probably the better. So helpful? Good? I don't know.
Yeah,
All right, cool.
Yeah,
Yep.